Welcome, everybody, to another night of virtual global spine. I am very happy to have my partner here tonight, Dr. Nick Pallotta, who is a deformity specialist. Um, I won't cut into his minutes too much talking about him or his work, um, other than to say that he's one of my favorite people to talk to because he's very logical and very smart, and he's very to the point. And I imagine this talk will be along those same lines. And so, um, with that, I will let Nick take it away.
Hi, everybody. Thanks for coming. I am, as Dr. Goodwin said, his partner at Washington University. My practice is focused on adult spinal deformity, and I'll present a little bit of my experience with adoption of patient-specific rods in adult deformity surgery. And certainly, I'd love to make it as interactive as possible. So in whatever manner we can do that. Happy to answer questions. Disclosures, just some fellowship and research support from Medtronic and non-financial research support from ATEC. I'll give an introduction on patient-specific rods, and then the heart of this will just be what my evolution in their use has been with some case illustrations, and then some conclusions and things I've learned along the way. So as an introduction, patient-specific rods are custom manufactured rods for individual patient anatomy. And these are rods that are made by the manufacturers prior to getting to the hospital. And they're bent in the sagittal plane, which is specifically tailored. As they're currently implemented, these are uniplanar bends in the rods. And then industrial manufacturing processes are used to minimize notching in the rods. And so you can see there on the right, this is just a CNC wire bender, and something similar to this can be used to very specifically bend a rod of the typical diameters that we're talking about for use with adult spinal deformity surgery. Doing the custom bending before the rods get to the operating room or even the hospital or even out of the manufacturing plant or allows for post-processing. And post-processing is any process you can implement after the rods are bent. So I have asked around to manufacturers on what sort of post-processing is done to rods, with only the confirmation that it is done, but not exactly what each specific manufacturer does, because these are proprietary processes, as it was explained to me, which is fair enough. But in general, post-processing for things like this can involve surface and/or heat treatments to remove either surface stresses or internal stresses. And these processes are aimed at increasing and improving the fatigue life and/or toughness of an object. So putting on my engineering hat for a second, this picture on the right is just an illustration of bead blasting. So that's where small media are essentially shot at a material to change the surface. And so this is one of the well-known processes for helping the fatigue life of really any product. So this does it by increasing the or imposing a surface compressive stress, which will inhibit crack formation or propagation through material. Heat treatments are other ways to reduce internal stresses in material, again, to help fatigue life.
So,
So the real,
quick question, really
yes,
stupid,
sir.
but so the pre-bent rods that people are using are machine bent, but the notching's less because it looks like you still might get some based on that machine, but maybe it's controlled better because it's done by the machine and not us with one high stress area?
Yeah, I don't think you're ever going to eliminate notching. You can't eliminate it. I mean, I guess if you bent the rod and then um, did quite an extreme heat treatment to the rod, that could potentially do it. But unless they do that, there's always going to be some level of notching. It's just going to be much less than the notching that you'll see with hand benders. And then, uh, you know, even if there's not notching, any bend will increase, will be a stress riser to the material. I mean, it just will. Um,
And what about 3D printing?
so 3D printing is not going to have, uh, it's not going to have um, the same kind of surface stresses, but the roughness of the material, the way the it depends on the kind of 3D printing, but essentially if it's sintered titanium, the way the titanium kind of melts together or sintered together, is going to produce a different kind of material that will affect the way cracks propagate through the titanium. So I don't think there's ever going to be, there's not going to be a perfect manufacturing process that eliminates the way materials fail due to fatigue. I mean, it's not going to happen, but certainly different manufacturing techniques will alter the fatigue life of these rods.
Gotcha.
So there's two main, I think with the concept of patient-specific rods as it pertains to deformity surgery, there's largely two main areas that I think would be the goal for this to help. And one is alignment, and the second is mechanical complications. So in terms of patient-specific rods and alignment, rods are manufactured to preoperative alignment plans that, as a surgeon, you will come up with. And surgical techniques can be added to the plans to alter sagittal alignment of a patient. So those are the well-known things we're all used to: osteotomies, interbody releases, or cages, amongst other things. You can even just change the intervertebral disc angle of each level, depending on the known or suspected flexibility of each level. And then planning interfaces can vary. So I've noticed two main interfaces. One is sort of what they call a concierge service. So you will talk with an engineer, tell them what your uh, goals are for surgery. They offer a plan back to you, and then you can say, yes, that's the plan, or I'd like to make these changes, and you can do an iterative process. The second type is a software interface with the surgeon, and then the surgeon can make their own plans, and then the company can manufacture a rod based on those plans. In terms of comparing pre-op planning with alignment, the data, at least for adult deformity surgery, are somewhat varied. And I think the variance is based on just how the studies were performed. These were two of the biggest cohorts on that subject that I have seen. On the left, you can see a cohort that had 17 patients with fusions of 3 or greater levels and an average follow-up of 16 months. And I think the biggest takeaway that is specific to assessing the accuracy of patient-specific rods with respect to implementing your plan is how the planned lumbar lordosis compares to the postoperative alignment. And I think, because that will be sort of intrinsic in the plan, the rest of the factors there will be somewhat altered by non-fused portions of the spine and or just simply how the patient is standing with regard to their lower extremities and hips. So if you look at the lumbar lordosis, actually they were able to get within a couple of degrees, which is probably within our measurement error, uh, which is fairly good. However, an average of 16-month follow-up doesn't tell us exactly how the alignment is maintained. And I think that's where the discrepancy here is between the two studies. So you have a second study on the right with a cohort of 20 patients, slightly different, greater or equal to 4 levels fused, but really a 2-year follow-up. And again, looking at the most specific measurement that would address implementation of the plan that was obtained preoperatively versus the actual goals intraoperatively, you can see quite a big difference between the PI-LO mismatch on the plan versus postoperative alignment. And this study actually noted they've had several failures, PJK and pseudoarthroses with rod fractures that affected the alignment. So I think they're looking at two different things. My take on this is that intraoperatively, actually probably they're fairly accurate, but that mechanical complications ultimately affected long-term follow-up. And so I look at this as saying, actually they're pretty accurate, but we haven't solved getting the spines to fuse or junctional issues. Which leads me to the second point here, looking at patient-specific rods and mechanical complications. So these would be major mechanical complications, including proximal junctional kyphosis and failure, rod fracture, and pseudoarthrosis. And actually, the data on this to date haven't really shown reduced mechanical complications with patient-specific rods. As far as I have seen, this is the biggest cohort that I've seen in the literature, a cohort of 86 patients treated for adult spinal deformity with minimum 1-year follow-up. And the mechanical complication rate just after 1 year is 18%, with 10% rod fractures, 1% pseudoarthrosis, and 7% symptomatic proximal junctional kyphosis. And you can imagine as time goes on, that percentage is just going to increase. And so I don't see that as being terribly different from the background of surgical treatment of adult spinal deformity. I'd like to share my experience and evolution as I've incorporated patient-specific rods into my practice. The first case I did was nearly 2 years ago. And that was actually this case, which was a 66-year-old male who had mostly calf weakness, minimal pain, and exam notable for an inability to toe rise, otherwise quite healthy. And his x-rays demonstrated a spondylolisthesis with some kyphosis at L4-5. And you can see the ankylosed L5-S1 segment through the disc space, which leaves him fairly flat in the lower lumbar spine. And he does have some level of pelvic retroversion. And actually, this was kind of fairly rigid, as you could imagine, on supine films. Actually, the spondylolisthesis I would have thought would have moved more than this, but actually fairly rigid, and you can see the severe stenosis he had on his MRI from L2 to L5. And again, you can see the ankylosis of the L5-S1 segment. And so this was sort of the planning. I didn't really think there was going to be any possible correction at the lumbosacral junction. I'd planned an interbody at L4-5 and some posterior column osteotomies above this. And this is what I came up with. I thought it would be somewhat difficult. This left us with me with a choice: pursue something like an osteotomy, or perhaps leave him slightly short of what I would consider perfect alignment. And so given his complaints. This is sort of what I went with. And you can see the implementation and the execution. And I do think this is a little bit short of the plan for a couple of reasons, and I'll show you that. Although this patient, I will say, was extremely happy, had basically no pain within a few weeks of the operation, surprisingly, and actually had a fair amount of neurological recovery. And he's now almost a couple of years out, and is doing quite well. But I did notice if I scrutinize these that I could see some coronal bend to these rods and recall that the rods are only bent in one plane. And so I concluded that the screw placement, because it is not perfectly in a line, especially in the distal lumbar spine, was actually affecting the sagittal plane correction using the rods. And so I thought about potential solutions to this, and I did implement using kind of offset connectors to help with this. So I'll illustrate that here in a patient that had a previous lumbar fusion from L3 to the sacrum, but also had a cervical thoracic fusion, was complaining of leg pain and numbness, did have a history of rheumatoid arthritis, but
Hey, Nick, sorry. Uh,
yes.
Before you go to the next one, that last case, the is this on the pro-axis bed? And then I was wondering if you would just talk a little bit about your thoughts on with using these rods and you know how easy they should be to put in. Meaning, should you have the correction you want and be able to lay the rod in there? Are you pulling the rod down some? Do you know what I mean?
Yeah, I think that that varies. To your second question. So for the first question, I believe this was pro-axis table, if I remember correctly, to help to both performing placement of the interbody cage and doing the transforaminal interbody work, but then also closing the osteotomies and able to extend the bed. So to that answer, yes, but I also typically do that for sagittal plane cases. I'll show you a case later on to kind of partially answer the other question, but for these cases, for the sagittal plane cases, I try to basically lay the rod in as much as possible, and I'll kind of show another step I've done with implementation of implant changes um, that to some extent have changed that partially, but basically if the spine is not loose enough, you aren't going to get the correction you desire regardless of the implants you use. So, uh, and I'll explain that a little bit more and you'll see that um, in the next case actually.
Gotcha.
Not this one. You can see this patient had the fusion. You can see some proximal junctional changes at L2, L3. You can see the old C3 to T3 fusion she had in, I think it was 20 years ago. Not by me. I'm not that old. Not yet. Um, and the scoliosis she has, and you can see the proximal stenosis, but she also had stenosis, which was quite significant at T11, T12. And so again, another one of these choices. I really didn't want to connect her cervical thoracic construct to the lumbar spine, although we did talk about it. We talked about leaving the thoracic stenosis alone because she wasn't symptomatic, uh, but ultimately decided to cover that so that she didn't become symptomatic from it. And I used patient-specific rods in her, and you can see that whereas the previous case, I had a lot of coronal bend in the rod, especially on the left here, you could see laying in a straight rod and using offset connectors to maintain that, and then placing the other rod as straight as possible so that all of the sagittal plane plan goes into the spine rather than into simply getting the rod to match the screws. You can see it's not perfect though. There's still some coronal bend. Did that affect the sagittal plane here? Maybe slightly. I think the plan here was a little bit more challenging in trying to figure out what her limits of horizontal gaze were going to be. I will say again, however, she's happy with how she's standing. So despite a bit of pelvic retroversion, I think this patient's still very happy and pretty much functioning as normally as she could be at this point, and basically pain-free. So again, happy with that. A little challenging on what the plan should be here, but basically what I noted here is that it's still a little futz factor to get these rods to sit correctly. And so what I ended up implementing was adopting a posted system in order to better utilize patient-specific rods. And I think this is where I'm going to sort of answer Dr. Goodwin's question on, well, what can you do with these things and the spine? And so the posted system, as you can see on the right, and these are not new. This is a 20-year-old textbook, which shows the TSRH system. But it allows different offsets from the screw to the rod and allows a little bit more degree of freedom to potentially ease rod placement. And I was not unaccustomed to using these. I was a fellow of Manish Gupta, who's used posted systems for adult spinal deformity, for the majority of his career. So I'd had some exposure to them and saw that they can be very useful with a uniplanar bent rod. And this will illustrate that. So this is a 72-year-old lady, a more recent patient of mine who had multiplanar deformity, an inability to stand up straight, very active, likes to go hiking in Colorado despite the spinal deformity. Otherwise very healthy, neurologically normal. And you can see on her 72-inch films just the severe deformity in both coronal and sagittal planes. Tipped very far off to the right. And I had some hint that there was some level of sagittal flexibility because even the big skin creases that you can see on the x-ray really relaxed when I had her lay down in the office. And you can actually see that starting on the far right, the sagittal plane did correct quite well. But despite that, the coronal plane is very stiff. Though if you look on the CT scan, you don't see much bridging bone and even maybe a hint of vacuum phenomenon. We did plan this out, and you can see the plan here. I was prepared to do, a myriad of maneuvers, including even 3-column osteotomies, but actually just doing some posterior column osteotomies at the apex of the deformity, and then using the sequential reduction capabilities of a posted system. This is maybe an answer to Dr. Goodwin's question. This spine, I would say globally was very close in terms of coronal alignment. But in terms of the scoliosis, it was still quite a bit off. And so I just sequentially and slowly reduced from the fractional curve up. And actually, though these rods didn't lay right in as you described, the correction came back all the way. I mean, I think at some point you have to make a judgment call, how much is too much, and whether or not you are going to just rip all your screws out. But actually this moved nicely, and I think her alignment turned out very well with just those maneuvers. And then finally doing something maybe a little more complex. I've actually gotten used to using the patient-specific rods for 3-column osteotomies. And so just to illustrate that, this was kind of a multi-step case, but this was a 75-year-old who presented with a few different complaints, but hand numbness and dexterity issues, but also severe back pain and inability to stand up straight in the setting of a previous fusion. Otherwise, actually fairly healthy. And she did have some signs of spinal cord impingement in the upper extremities. Lower extremity exam actually mostly normal on manual testing. And so you can see on the long lateral, she has the previous instrumentation. She's bending her knees to try to stand up straight. What's difficult to see here is you have a complete failure above her fusion, which is in part the cause of her inability to stand up. And so actually, cross-sectional imaging demonstrated she had this stenosis, which actually is probably underrepresented here, but it's quite severe from C3-4 and then also at the cervical thoracic junction at C6-7 and C7-T1. And then you can see the complete collapse of the L1 vertebral body there and the stenosis above her previous instrumentation, which stopped at L2, and then multiple pseudoarthroses, and had again a debate with this patient because of the magnitude of what we were considering, and actually sort of decided to do all of it. So we did her cervical spine, let her recover for a couple of months, and then did the planning on how to correct her sagittal plane. And actually what you can see here is I was going to utilize a satellite construct, and I got very small satellite rods created custom so I could see the correction, and then the long rods, which would connect her from top to bottom. And then you can see how that turned out with the satellite construct and spanning rods. And this was, as you could imagine, tough for her to recover, but actually she's over 6 months in, walking, still with a walker, but walking, and has really minimal, if any, pain. So it actually turned out fairly well.
And so you on that one you had the satellite rods for your PSO custom made, and so when you start bending that, after you've done your PSO and you start correcting there, you're kind of using that as a template.
Yeah, so the posted system, I use essentially two modes. They can be monos, essentially true posts, so monos, or alternatively, they can turn into sort of a polyaxial screw. So what I do at the PSO site is use the monoaxial function so that as long as the screws are, fairly parallel to the end plates, I can actually use that as the template as I reduce that. So as they're tightened, they're basically showing me the angle. And then I know that I'm pretty good with the sagittal plane within a few degrees probably. And then place the long rod to get the global alignment right.
I see.
And so my conclusions from using patient-specific rods are they allow for easy preoperative planning, and that plan is then transcribed for you into the rod. And it can act as an intraoperative guide. So if you're not sure if you need to do more releases, as Dr. Goodwin was alluding to, you can lay the rod in there, and if the rod doesn't just lay in there, you can do more releases until the spine gets to the shape that you want. I think the rods are stronger than traditionally bent rods. I have not had a rod fracture yet. That's only because I haven't been using them long enough. I'm assuming in the next calendar year I'll have some rod fractures associated with this so I can get a better indication of what the rate is. And we've seen from the literature that they're not immune to rod fracture. For me, adding the posted system eased use of the patient-specific rods because it allows you to implement the uniplanar bent rod even in multiplanar deformities uh, fairly easily. And the one big thing I've noticed, especially when comparing doing these more elective type cases in comparison to something like a trauma where I may not have them, is there's a lot of time saved in the operating room um, between placement and checking of pedicle screws and placement of the rods for final x-ray. I would say that of the surgical intraoperative things, that's one of the most significant. And I would like to take certainly any questions.
All right. Well, first of all, that was fantastic. My question. Well, first of all, I've done barely any of this, but I will say that your last slide there, the serving as a template, I thought was the most amazing part of using pre-bent rods, and that when you're when you have it planned, I certainly remember doing cases with Mike, and I remember we did some stuff, bent the table, and then we got an X-ray, and then it was like, oh, it's too we put too much lordosis, let's bend it back, another X-ray, and versus when you have this, I don't think until I used it did I appreciate how you start doing your correction and you can kind of lay the thing down there as a guide or a template as to where you're going, which I thought was incredibly nice. All right, but my question is about rod size that you're using, and then kind of revisiting kind of the other old questions that go with that since we have you, which is rod size, number of rods. I think everything you showed was either two rods or two rods with the satellite rods for the PSO. Um, and your thoughts on rod material. I'm a tumor person, so I'm using titanium almost all the time, but um, love to hear your thoughts on size, number, and material.
Yeah, probably do that in reverse. So I pretty much always use 6.0 titanium for um, most cases. Uh, I find cobalt chrome pretty stiff. I think 6.0 cobalt chrome is like, I don't know, the devil's rod or something, especially trying to bend that yourself. Did that once and that was enough. Um, I like 6.0 titanium. There's some, I'll call it proprietary data from one manufacturer that showed me that the run out stress of it, so the stress at which or I guess run out force, the run out force of a 6.0 titanium rod, that's what the loading you can apply, where you'll have essentially infinite cycles of loading. It won't fail. Was higher for 6.0 titanium than for other commercially available rods. That was the highest. So there's a lot of things that play into that. That's a very theoretical sort of laboratory value. It doesn't take into account all the stress risers and your reaction to them. It doesn't take into account notching, which is a stress riser. Now that should be minimized with the patient-specific rods. So I would think that, they should be amongst the strongest. So I pretty much usually use 6.0 titanium. I will use cobalt chrome if we're doing thoracic VCR and I'm using the bending of the rod to actually alter the alignment. I've tried to do that with titanium. Titanium just too elastic. You lose a bunch of the bend you put in. I've tried switching them out actually after that, but then you lose a little bit of correction for the same reason. So those cases, I'll use cobalt chromium. In terms of rod number, usually I use the 4-rod construct that you saw with 2 satellite rods for PSOs. I will say I've pushed this a little bit with these patient-specific rods, and I, again, haven't seen a rod fracture yet, so I'm just waiting on that. But for L5 PSOs, because of the distal fixation issue, I've actually done a couple of cases with 2 rod constructs, kind of banking on that increased strength of these rods. Again, I haven't seen a rod fracture yet. I'll tell you when I do. um, so mostly for rod constructs around osteotomies, rarely 2. Um,
And what if you're doing? And what if you're doing? What if you're just doing multiple PCOs, and maybe you did ALIF, and maybe it's a T10
yeah,
to pelvis, something like that? Are you
yeah,
still doing?
I pretty much go with 2 rods. Yeah, 2 rods. It's just been my feeling. It's not been perfect. Well, so far it has with these, but it won't be. It won't be. I have no illusions about that.
And adding a third rod to a case like that, you think biomechanically?
I don't know. Your lead time to complete construct failure might be longer, but I don't know if that represents longevity, like 10-year longevity, or if that just represents like from, let's say, 18 months to getting out to 3 years, something like that. So, and I can tell you the saddest patients I've had are the ones that have rod fractures between 2 and 3 years. Not even potentially patients I've operated on, but ones that have been operated on previously by excellent surgeons and have great results. And then, let's say like 30 months, have a rod fracture, symptomatic. I almost think, I don't know, they just seem sadder to me because they're just kind of getting back to life and then they've got to start over.
And this is typically let's say I don't have the pre-bent rods at my disposal. It sounds like from what you've said so far that bumping to 6.0 titanium would be, you would think would be advantageous if I'm using 5.5.
Yeah, I think, well, the bigger diameter is going to be less sensitive to notching. Small diameter rods are going to be more prone to crack propagation and breaking. So I don't use 5.5 titanium unless, you know, shorter construct, with a very osteoporotic patient.
Gotcha.
Yeah.
Excellent. Well, Nick, that was fantastic. Thank you for presenting that, and particularly for the cases and showing some of the evolution of and how you think about it, because I'm oftentimes trying to steal things from you that I can use in my practice. Um, great. Well, thanks again, and thanks everybody for joining. A lot of nice comments here from the audience, and we'll plan on seeing everybody next week. Thanks again.
Thank you. Thanks, everybody.